This is kind of looking more long-term on your hip replacement and what to expect afterwards. And so I showed you this slide earlier just to describe the leg length discrepancy, but what happens, what do you expect after your hip replacement? The main three things are improvement in pain, improvement in function, and then returning to normal activity. So with osteoarthritis, you have bone-on-bone grinding that creates a lot of pain. With this procedure, since we're removing that arthritic bone and replacing it with these metal components, you'll have 95 to 98% improvement in pain. This includes with your walking, your gait, all of that. The 2% that I mentioned is just normal soreness that everybody gets with walking and things like that, and so you won't have that same sort of arthritic pain that you're experiencing now. Improvement in function, meaning you'll be able to have the more mobility, more range of motion, and you won't have any issues with your walking. And then returning to normal activity, you'll be able to, that's the component that comes with the improvement in strength and endurance and all that. And so low impact activities are highly encouraged. These are walking, hiking, swimming, biking, those sort of things. That plastic liner within the cup, because it's articulated or in contact with this ceramic ball, it can wear down, especially with higher impact activities, because the hip joint is a weight-bearing joint. And so we you won't be able to do any sort of running or jogging or jumping after the surgery because of that wear on this. And so with the wear, that means another surgery to replace it, and you won't get the longevity out of that joint that it's intended for. And then, so immediately in the first 4 weeks after surgery, not only are you having to heal within the actual joint, but then there's that skin incision where we used to access that joint. And it's typically about, I would say, 3-4 inch incision on the front portion of your hip. And after the surgery, they'll close it with absorbable sutures, and so there's no need to remove any sort of stitches afterwards, and you'll have a water-resistant dressing over it. I would recommend keeping that dressing as dry as you can for the first 2 weeks until you follow up with our clinic. After that, the dressing will be removed in the clinic, and you'll have this mesh over the incision that's held together with super glue, or the surgical super glue that we use. And so that's just another way that we use to close the incision or make sure that it's healing.
And that's during the surgery.
Yes, this is during the surgery. So, but that's what you'll expect after we take off that first dressing. After we take off the dressing, you'll be able to leave it open to air. You'll be able to run water over it. You'll be able to clean it. But we don't want you using any sort of lotions or scar creams or any sort of topical stuff on it. And then we don't want you submerging it in baths or pools or hot tubs or anything like that for the first 4 weeks. After that, we can start using those scar creams and everything like that afterwards. But those are kind of the main considerations in the first 4 weeks regarding your skin incisions. After the first 4 weeks, it'll be completely closed and healed, and there's no risk for it coming apart with the submersion or anything like that. And so that's why we have that 4 week time period. And I'm gonna go over a little bit later on what to look for in terms of infection and stuff like that. So pain management afterwards can be kind of tricky, and we base our pain management regimen off of each patient and their needs. And so typically, like I said, we'll have three mainstays for pain management. That's the Norco, which is a opioid, it's a narcotic, and then tramadol, which is a lower pain medication, and then ibuprofen, which is more of an anti-inflammatory. And so the Norco can be taken up to 3 times a day, and this is just a example of how you can space out your medications. And so the Norco can be taken at night, and then at lunch, or in the morning, then at lunch, then at night to help you get to sleep and get that steady pain relief throughout the day. The tramadol can be used for breakthrough pain if the Norco is not sufficient, and then the scheduled ibuprofen can be taken 3 times a day to have with the anti-inflammatory coverage. And so a great way to kind of make sure that you keep organized is using one of these pill boxes. And if you're already on one of these pain medications for another condition or pain management, we'll kind of adjust to your needs, and it'll just be on an individual basis. And so sometimes this isn't all like a cookie cutter for each thing, or each patient. We just have to individualize it.
When do we talk to you about allergies?
To any of the
Norco, for instance.
Yeah. Well, if you have allergies for Norco, or any of other, we'll make sure that the pain medication we give you does not have any interaction or has any effects, and so it'll just be on that individualized basis. And so there's a lot of other things that we can use besides the Norco, but the Norco is just the main one that we do.
When do we discuss that?
It's typically before surgery.
Yeah.
And then we'll make sure that in the hospital what the pain medication they're giving you doesn't have any interaction, and go from there. Okay. And then if you have any specific questions, you can always give our office a call afterward or before the surgery, just to make sure. But we'll make sure that we check all those things like allergies and any sort of, if you're taking medication that could interfere with the pain medication, we make sure that's on an individualized basis. But and then physical therapy kind of went on what the physical therapy looks like in terms of the home physical therapy and outpatient. Your activity specifically, sometimes after surgery, there's a certain time period that we want you to not drive, and really this is based on driving reaction time with your hip, being able to move your leg over from the gas to the brake. And so really it resumes whenever you can comfortably bend your hip and knee enough so you can move, enter and sit into the car comfortably, as well as being able to have that reaction time to move from the brake to the gas. And so we typically do this at the first post-op visit, just assess how you've been doing with your pain and your range of motion, and then recommend it, driving around in a parking lot in an HEV or something, just to kind of get back to that normal routine, and then before going on to some more busier crowded roads or on highway or like 1604 or something like that. So
even if it's not your driving foot?
Even if it's not your driving foot. Typically with if it's your left foot or left leg hip that you're going to replace, you'll be able to resume driving earlier, but we still kind of make that assessment at 2 or 3 weeks, so it'd probably be within 3 weeks that you'd be able to resume driving if it was your left hip, unless you drive like a standard car or something like that. But the right hip, it may take a little longer just because it's your main driving foot. Obviously, if you're on any narcotic pain medication that makes you drowsy, we don't want you driving on that. And so if you're still on pain medications for that, we don't want you driving. I forgot to mention with the pain management, with the plan that we have in place to have it scheduled and have that good pain management coverage, as well as working with the physical therapy to get back your range of motion and strength. By 6 weeks, you shouldn't be on any narcotic pain medication, just using the ibuprofen and Tylenol as needed for any aches and pains like that.
6 weeks?
6 weeks after surgery. So with hip replacements, the best rehabilitation to get you back faster is just using it and walking and those sort of things. And so that's what we really push for after surgery. And then you'll probably be using a cane for the first 2 to 4 weeks, and then begin outpatient for physical therapy. About 6 weeks, you'll be off the pain medication, just ibuprofen, Tylenol, be walking without a cane. 10 weeks, you'll complete that outpatient physical therapy and continue doing the home exercise programs and walking. And 3 months, you'll get back to where, 3 to 4 months, you'll get back to where your gait and function is pretty much normal. May have a little bit less stamina, endurance, but you'll still have steady improvements. And really, the 6 months to years where you get, you'll be getting back to your normal routine. And about a year or 2 years after is kind of the best it's going to get. And so we really try to get the rehabilitation done in the first those first 10 weeks to really set you up to have good outcomes, you know, at 1 year out. And so these are typically the times that you'll follow up with us, and at each visit they'll take an x-ray of your hip, and we'll make sure that the prosthesis is still in place and there's no evidence of it loosening or other abnormalities with the x-ray. We'll assess your range of motion and kind of strength at that point too, and see how you've been progressing through physical therapy. And the physical therapist, they send back their notes for each session that you guys do with them, and then we can kind of assess whether you need more physical therapy or if you're good to go, and kind of it's based on an individual basis as well. And then the last thing one of the last things I like to hit on for long term afterwards is for preventing infection. With any prosthesis or joint, the risk of infection is very low. It's less than 1%. But when there is an infection in that joint, it can be pretty detrimental, and we'll have to go and do another surgery to fix that. And so any sort of dental procedure sometimes can cause bacteria in your mouth to get into your bloodstream, which then travels into your hip joint, and so you'll need to have antibiotics before any dental work. This includes dental cleanings, crowns, any sort of teeth getting worked on. And so you can give our office a call and we can send you a prescription, and if you have any allergies, we'll make sure that the antibiotic doesn't interfere with that. And then you'll just take the antibiotic 2 hours before that procedure, and that's it. That's for that. In terms of when you can have dental procedures done, it won't be until 6 months after your hip replacement. And so if you're getting any dental cleanings, I would recommend getting them done before. That way there's no risk, or you don't have to postpone those or delay those afterwards. But the minimum amount of time before you can get any dental work after a joint replacement and hip replacement is 6 months. And then blood clot prevention. We kind of went over all these before, and really that time period that it's most crucial is within the first 4 weeks. And so you'll be on the aspirin for 4 weeks. Afterwards, you'll discontinue that and just keep walking and stuff like that. Those will be your mainstays of preventing blood infections. We also have compressive socks that they probably discharge you with at the hospital. These kind of reduce swelling and can help promote blood flow in combination with walking and stuff like that. And then there's a lot of different, if you're sitting down like watching TV, there's foot and ankle exercises that you can use just to keep your calves moving to promote that blood flow. And so these are the last things I wanted to go over. With any surgery, there's these risks. I want you all to be aware of any potential signs or symptoms that could indicate these. So infection, if you're having any fever, chills, if there's increased swelling or tenderness around the wound or surgical incision spot, if you get drainage, if you have increased hip pain that's not improved or that's worsening from the surgery, this could be an indication of an infection within the joint, and we'd have to investigate further. For blood clots, if there's any pain or tenderness in your calf, if you get any redness around the area, swelling, those are signs of a deep vein thrombosis or blood clot in your leg. And then if you get sudden shortness of breath or chest pain with coughing that's localized and it's acute onset, then those are signs of like a pulmonary embolism or blood clot in your lung, and those would be indications to go to the emergency room to get that evaluated. The risk of these is very low, especially with the implementations we have in place with the aspirin and early walking and all those things, and then with our antibiotics that we give you during surgery, after surgery, and then when you take them before potential procedures. So all these are very low, but I just wanted to bring your attention to these in case they, if you do have signs of those, you should call us, and especially if you're having those acute and severe symptoms, then definitely go to the emergency room. And so that's the end of the presentation.